So good morning. Thank you, Claire, for the nice introduction, and I would like also to thank the organizers for inviting me. And my pleasure is today to share with you some of the new updates of the WHO with regard to myelofibrosis, and in particular also the definition of what we now call the pre-fibrotic stage of myelofibrosis. So why should we have a new classification? So indeed, this is an update of the 2008 classification, which stresses in particular an integrated approach which includes all available key morphological data, all molecular data, and also the clinical pathological correlation. And this is not a definition by hematopathologists. It's a work and team approach which integrates the advice and consent of important clinicians in the field. So this is not only a pathological definition. So what are the updated diagnostic criteria for myelofibrosis? Indeed, the major issue is to refine the diagnostic criteria for early stages of the disease. So emphasizing also the clinical importance to catch these early stages of myelofibrosis. And by this also, there was a need for a better definition of the clinical, that means the minor clinical criteria for the pre-PMF cases. And we also needed some refinement of the histomorphological features which are the key to make the diagnosis of pre-PMF, and in particular also in view of, let's say, reproducibility in most practice settings. So how can we apply this criteria for daily diagnosis? And finally, also the integration of new molecular data, prognostic important molecular data, and also data from the molecular point of view, which are important to establish the diagnosis of an MPN, in particular myelofibrosis. So it still makes sense to differentiate the subtypes of MPN. And by this, you see that the survival probability of myelofibrosis is by far very low as compared to ET or also PV. And we have also learned from the recent studies that age still is maintained as a prognostic important variable also in myelofibrosis. So what about molecular data? And we have learned a lot about molecular data. I just want to focus on the triple negative cases, because we know that around about 5 to 10% of myelofibrosis cases have no phenotypic driver mutation. That means they have no JAK, no calreticulin, or no MPL mutation. And keep in mind that these triple negative cases might be mixed up with cases of MDS-MPN overlap, and also with cases for myelodysplasia and myelofibrosis. So it's very important to be sure that you don't mix up these cases with a totally different disease, which also have totally different risk of progression. And in our experience, the frequency of real triple negative PMF cases is really low. It's far below 5%. And actually, I think that our methods to detect the phenotypic driver mutations are not sensitive enough, or even perhaps have unknown mutations in these cases, which you do not catch with our standard assay. So anytime I see a case which is labeled triple negative PMF, I always question whether this case has cytopenia, whether this case has dysplastic changes, and you can't make the diagnosis alone by the bone marrow biopsy. You need the full clinical information that also includes the smears, it's the peripheral blood, and also the bone marrow smears to, in particular, assess the amount of dysplasia. So, in view of this, the WHO has now defined diagnostic tables for the early stage of myelofibrosis and also for the advanced stage. When you remember the 2008 edition, there was one major diagnostic table for myelofibrosis, and there has been a comment that myelofibrosis may also present as a very early stage. The problem was how to apply these criteria to the very early stages, in particular also with regard to the clinical criteria, to the so-called minor criteria. By this, the WHO now has decided to emphasize the importance of early-stage myelofibrosis and labeled it pre-PMF or pre-fibrotic myelofibrosis. The definition is put in a separate table, and this is a table which will be in the book. It is a disease stage which has no significant myelofibrosis. That means without reticulin fibrosis more than grade 1 according to the WHO definition. It is a disease which does not meet the criteria for the other MPN subtypes like ET or PV. In particular, it's not BCR-ABL positive. And it should have one of the driver mutations. That means it should be JAK positive or calreticulin positive or MPL positive. And if you had no evidence of clonal disease by assessing these phenotypic driver mutations, you should be very sure not to mix up a reactive condition. Think about autoimmune fibrosis, think about like MDS-MPN or MDS with fibrosis or even without fibrosis. And it's recommended to go further in molecular testing, in particular in young patients, to see for some prognostically important somatic mutations like listed here in the lower part of the slide. The key to make the diagnosis of a pre-PMF is the bone marrow morphology. It's the morphology of the megakaryocytes, it's the proliferation, it's the atypia. This is unique to this subtype of MPN because in ET and PV we don't see atypical megakaryocytes. And it's not only the cytomorphology, it's also the combination to the abnormal histopathology, that means histotopography of the megakaryocytes. And we see atypical clustering, or what we call as a dense cluster in pre-PMF, which is not seen normally in ET or PV. So the atypical megakaryocytes, we can easily appreciate it also on the smear, but much better in the tree-fine core biopsy are the key to make the diagnosis. And ET is totally different. So ET is not pre-PMF. And just by regarding cellularity, you see that in the ET cases, you normally see normal cellular bone marrow, whereas pre-PMF is characterized by a hypercellular bone marrow, increase in granular poiesis, increase in megakaryocytes, and increase in atypical megakaryocytes. That's the key to make the diagnosis. So how about the question of minor criteria? The problem is that the early presentation of myelofibrosis can be mixed up with essential thrombocythemia. So there's no clear black and white pattern to make the clear differentiation between pre-PMF and ET just on the ground on clinical presentation. And this is our own data, and there have been in last 2 years other studies independently showing exactly the same data, that you might have some anemia in pre-PMF, but this does not exclude ET, because also in ET you might have some slight kind of anemia. Spleen size is more often a feature of pre-PMF, and in particular also increase in LDH is more prominent in pre-PMF cases, whereas in ET is a very rare finding. There are absolutely no blasts in both diseases, and we have learned from studies from the Italian groups that leukocytes are important a feature in pre-PMF. So around about half of the cases of pre-PMF, and even more in our own data, now we see more leukocytosis is more prominent in cases of pre-PMF, whereas ET is not as common presenting with increase in leukocytes. So by this, the WHO now has decided to cut down the requirement of 2 minor criteria only to 1 required minor criterion, and this does include anemia, this does include the leukocytosis, the LDH increase, and also the palpable spleen of any size. So if you have one of these minor criteria in combination with the major criteria, these are the morphology, these are the phenotypic driver mutations, you are able to catch around about 95% of pre-PMF. So in other words, the frequency of MPN unclassifiable should be around about 5 to 10%. And if in your own practice you have higher amount of MPN unclassifiable, you should refine the diagnostic criteria, because it's an integrated approach and it needs the information from the marrow and also the information from the molecular and clinical findings. So for the pathologist, in the book there will be this table that's from the book, highlighting the major differences between ET and pre-PMF. It's the cellularity, it's the atypia of the megakaryocytes, it's the hypolobulation of the nuclei, and the dense clustering of the megakaryocytes. And this is reproducible. There have been a lot of discussion after the 2008 edition whether prePMF is an expert diagnosis and cannot be applied in a routine setting. And just give you an idea about the, let's say, the assessment of concordance between pathologists in the field of prePMF, and around about 82% is the grade of concordance between pathologists when they do a formal assessment of agreement and also include an integrated approach, which means not only the marrow, it means the morphological pattern and the inclusion of key clinical data. So why does it matter to differentiate ET from prePMF? So first of all, we have difference in biology. It's related to the mutation load. It's related to the atypical megakaryocytes that make alteration of function differentiation. We see different amount of circulating progenitors, and we have also now new data on gene profiles which are different between prePMF and essential thrombocythemia. We see differences in clinical outcomes, so that's survival, that's the risk of progression to overt myelofibrosis, and also the risk of leukemic transformation. And by this, the question arises how to prevent the natural progression of prePMF. Do we need to start early treatment, or do we have any treatment options to prevent the dynamics of the disease? Just to show you the difference in mutation load, on average, ET has a much lower mutation load than prePMF, but keep in mind that the prePMF has a wide range of mutation loads, so low mutation load does not exclude prePMF. But if you have a higher mutation load, let's say more than 70%, this is normally not seen in essential thrombocythemia. This is for JAK2. Interestingly, we don't see the same effect for calreticulin. So far, there's no published evidence that there's a difference in mutation load for calreticulin across all these subtypes. So ET and prePMF is exactly the same mutation load. We know that there are gene expression profiles which are different between ET and prePMF, and these are new data showing that genes which are involved in inflammation, differentiation, are totally different regulated in prePMF. Makes sense because myelofibrosis, which will come out in the later stage of the disease, is triggered by inflammation. We see difference in survival. So ET is a more or less benign disease which has no impact on overall survival but has a risk of complications. And prePMF has a significant loss of survival probability. These are our own data, also data from Italian groups, and this has been confirmed also by Austrian study groups. And we see different risks of myelofibrotic transformation. So in other words, prePMF is not a stable disease, it is a dynamic disease. Unfortunately, we cannot predict the speed, and we cannot predict the time point of progression to overt myelofibrosis. But overall, the bottom line is the risk of overt myelofibrosis and also the risk of developing blast phase or acute leukemia is much higher in prePMF than in essential thrombocythemia. And interestingly, there's also a difference in the risk of complications. And this is very important because we see a much higher risk of bleeding in atypical thrombosis in prePMF. So major bleeding mainly associated with high platelet counts in prePMF, and this is much more common in prePMF than in essential thrombocythemia. And we know from published data that in these cases, even low-dose aspirin, which is a standard treatment to prevent these complications, may even exaggerate the hemorrhagic events. Cases which have a typical presentation of thrombosis, that means planchnic vein thrombosis, mesenteric thrombosis, these cases, in most cases, belong to the group of prePMF or even PV, but it's relatively rare to see a T patient presenting with this atypical presentation of thrombosis. And we have learned that leukocytes, that means high leukocyte counts, clearly correlate with the risk of thromboembolic complications. So that makes sense to include this feature in the clinical criteria, in the list of the minor criteria. So overall, the risk of complications is much higher in prePMF than in essential thrombocythemia. And when you look at the combined event-free survival, around about the risk of complication or the events per year is 2.5-fold higher in prePMF than in essential thrombocythemia. So in other words, we have a difference in mutation load, we have a difference in circulating progenitors, we have higher rate of progression towards overt stage of myelofibrosis, and also we see more complications, clinical complications with regard to bleeding and high platelet counts. So for overt myelofibrosis, there's no major change. You need a fibrotic marrow, that means more than grade 1, 2, or grade 3, according to the WHO definition. You have one of these driver mutations, and if you don't have clonal evidence by assessing these driver mutation, it makes sense to go further for molecular testing because the additional somatic mutations are prognostically important. The list of minor criteria is amended in the revert stage by leukoerythematosus because we know that in the revert stage of PMF we have a high number of circulating blasts, so this makes sense to include this as a clinical criterion. From the WHO, there will be a comment about the heterogeneity of morphological presentation. Even in the advanced stage, we see cases which might be hypercellular, and we also see cases which are hypocellular or even depleted. This makes sense to have an impression about the cellularity of the marrow, because if you have a hypocellular marrow in an advanced stage and you start some of these new treatment options, you can bet that this case will get cytopenic because there's no cellularity in the marrow. There will be new grading for collagen and osteosclerosis for the pathologist. This is not for the routine setting, but that's for studies, because we have learned that there's a delinking of the fibrous metrics, in particular after these new treatment options like JAK inhibition and also after transplantation. So the pathologist will get some guidelines how to assess the fibrous metrics. And we have learned, and this will also be emphasized in the WHO, that mutation and mutation status is important with regard to prognosis. Keep in mind that calreticulin mutated PMF is always a better clinical outcome, in particular the type 1 or type 1-like mutations of calreticulin have a better prognosis. And also keep in mind that the cases which have a triple negative phenotype should not be mixed up with MDS-MPN overlap or even MDS of myelofibrosis. And if you have these somatic mutations, if you have none of these, normally the survival is better, and if you have one or even more than two of these, normally the survival is very bad in myelofibrosis. So how about bone marrow fibrosis per se? So it's called primary myelofibrosis. It means fibrosis in the marrow. We have learned from historical studies, even from our lab, that myelofibrosis is important for prognosis. And the good thing, it has been now confirmed in the last 2 years that myelofibrosis seems to be an independent prognostic feature. So early stages have a better prognosis than advanced stages. And most importantly, it does not totally correlate with the clinical presentation, that means with the clinical risk stratification. So if we just focus on the low risk and the intermediate 1 cases, which are defined by the IPSS, you see there's a heterogeneity of presentation with regard to bone marrow fibrosis. And even in intermediate 1 cases, you can see cases which have a high amount of reticulin or even collagen or even osteosclerosis. And we know that these cases have worse prognosis than the non-fibrotic. So it makes sense to integrate bone marrow fibrosis in the field of prognostification. And this has been confirmed also recently by the Italian groups, showing that in particular in the low and intermediate 1 cases, the assessment of bone marrow fibrosis gives you some additional prognostic data because it has impact on the overall survival, whereas in advanced stages or clinically high-risk cases, the exact assessment of bone marrow fibrosis has no additional prognostic value. And if you put it all together, integrate the molecular findings and the marrow fibrosis, you see that increase in bone marrow fibrosis is normally associated with high molecular risk status. So around about 45% of MF3 cases, fully blown MF cases, have a higher risk mutation status, and around about 33%, 1/3 of cases with MF2 have a high mutation risk status. So it seems to be that the frequency of high mutational risk status increases progressively with the grade of bone marrow fibrosis. So coming to the end, myelofibrosis is a dynamic disease. It starts with a very early stage without myelofibrosis. It's like carcinoma in situ. It might present like essential thrombocythemia with increase in platelets. Keep in mind that these cases, which are pre-PMF, have a higher risk of complications than the common ET case. They have normally no huge spleen, no blasts, but they might have a slight increase in LDH, and they progress towards the full-blown disease stage, the overt myelofibrosis with the clinical presentation, with the change of the phenotype, that means spleen, blasts, LDH, and severe anemia. And this is also supported by the molecular background. That means we have additional somatic mutations which play a prognostic role, and we also have some different types of progression. We have MDS-like progression, we have MDS-MPN-like progression, and overall these points have all now been included in the updated WHO. So in pre-PMF, differentiation from ET is underscored by the standardization of the bone marrow features. This is for the pathologist, and also in ET, it has been emphasized that reticulin, an increase in reticulin ET is not compatible with the diagnosis. So in other words, if you see a case of reticulin, you should think twice about making the diagnosis of essential thrombocythemia. In pre-PMF, the minor criteria have been much better defined, and we have learned that the number of acquired somatic mutations is prognostically important. Many thanks.